This is ACEP President-elect Ryan Stanton inviting you to join me at ACEP 26, October 5th through the 8th in Chicago. Your specialty, your people, in one place. Register now at acep.org/ACEP26 and get free access to ACEP anytime. I hope to see you in Chicago.
This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast, July 2026. Happy 4th of July, Ryan.
Happy 250th birthday, America.
Do you guys even celebrate it down there?
Why would we celebrate America's independence?
Well, I thought there's a bunch of the expats who live down there. You guys get together and, live your glory years out.
Oh, we had a wee little get together. Nothing exciting. It is the dead of winter. You can't have a barbecue and traditional things.
And shoot off fireworks.
Well, there are fireworks here because it's the winter holiday of Matariki, which is the rising of the Pleiades star cluster. It's a traditional holiday in Maori culture.
That happens at the same time as the 4th of July?
Roughly. It's
okay.
It's astrological as opposed to calendar, but yes.
Yeah. Okay.
Yeah. But that's our winter. That's our winter holiday of sorts.
Nice.
All right. Now you're learning, everybody.
I think you go first.
Sounds good. The first article we'll talk about from this issue is called Social Vulnerability and Out-of-Hospital Identification of Neurologic Emergencies. Our lead author here is Andrew Wood, and they are at the University of California, San Francisco. And this is a very focused and tidy study, I think, and it comes to a fairly valid conclusion based on the data available. In this study, the authors are looking at social determinants of health and, in this instance, the effect of those social determinants of health on early treatment of neurologic emergencies. It's a big old grab bag of EMS system data with 60,000 patients, and it ties the initial impressions and treatments initiated to the subsequent diagnoses from the receiving hospital, specifically stroke, intracerebral hemorrhage, traumatic brain injury, and status epilepticus. Their primary analysis is by quintile of the so-called Social Vulnerability Index, which is a nationally available percentile ranking by census tract, composed of 4 domains: socioeconomic status, household composition and disability, minority status and language, and housing type and transportation. Obviously, like we always do on the show, we encourage the truly invested reader to comb through all the pearls, but the best takeaway comes from Figure 2, where the authors break down the relative risk of having an unidentified neurologic emergency, depending on the various social factors involved. And yes, as you would readily expect, social vulnerability quintile increases this risk of unidentification in a dose-dependent fashion. Interestingly, however, the types of neurologic emergency matters. Stroke and traumatic brain injury were less likely to be diagnosed concordantly with the hospital, whereas status epilepticus and intracerebral hemorrhage were a wash. The authors speculate that these diagnoses are potentially the most sensitive to subtle findings or environmental factors infecting initial care and are more likely to be affected by language barriers or housing conditions. Luke Wolford and Regina Royan write an accompanying editorial focusing primarily on the issues associated with early identification of stroke and the downstream missed opportunities for intervention. This dovetails nicely with other work we've presented here within the past year, looking at whether comprehensive stroke centers tend to serve more affluent areas as well. And I agree the underlying causative factors merit further investigation.
Yeah, I think that's the final key is what are the causative factors here and how can we fix them? It's not hard to imagine that these social vulnerabilities do matter and increase the rate of misdiagnosis upstream and possibly downstream, though we can't say that from this article. But what are the causative factors and how we can fix them is obviously not in the context of this article.
I'm sure we'll see more from this team.
Our next article, Comparing Patient-Centered Approaches to Social Care in Emergency Department, a Mixed Method RCT. And the lead author is Rachel Brown out of Children's Hospital of Philadelphia. So over 40% of ED patients and families report at least one unmet health-related social need when presenting to the emergency department. But the best way to screen for these needs and how to best serve the patients is still unclear. So what these authors did was basically set out to do a study to try to figure out the optimal way to screen for these patients. Now, this is a subset of a bigger study called the SECURE trial, or Social Equitable Care by Understanding Resource Engagement trial. The larger trial enrolled at 3 sites, 1 pediatric ED and 2 pediatric primary care clinics. This paper presents only the ED subgroup. And what they did is they enrolled the adult caregivers of pediatric patients and randomized them into one of 3 arms, essentially the best way to screen for social needs. And the first first arm was the screener arm, where caregivers answered a screening tool to assess both for social risk and social needs across 5 domains, and then were given an electronic map to support the needs that they screened positive for. The second was a menu arm, where the caregivers basically selected their desired resources from various domains as if ordering off a menu, and then were given the same map based on the resources they selected. And then the third arm was they were just given a map, various resources that they could use as chosen. There was a 30-day follow-up by text to find out what resources were used and whether the patient's family members themselves used them or these resources were shared, so on and so forth. And then finally, at 6 months, they did a qualitative survey of a subset of these patients, basically asking the caregivers about their experience, what things went good, what things went bad. The primary outcome was basically which of these arms best identified the social needs that the patient's caregivers require. So overall in the sample, there was close to 2,000 patients, a little over 650 in each arm. The population was mostly publicly insured, and there seemed to be fairly well balanced throughout the groups. What they found from a primary outcome, there was a significantly higher rate of asking for specific needs in the menu group versus the screener group. So 39.6% versus 31.7%. So a 7% difference. And the biggest areas where the gaps were in food and housing. Not surprisingly, the amount of engagement on the map increased with the amount of domains that someone had desire to get support in. So if you had one, the completion rates of actually getting resources with the map was 8.1%, and it went all the way up to 53% if you were interested in 3 or more domains. Overall, from the follow-up survey, 45.8% used the map and 36.7% shared the map with other people. As far as the qualitative themes that came out in the survey, there was a number of things that the caregivers kind of discussed, and mostly it was related to when these screenings happen. So basically, when you come in the room, be quick and clear about what your role and what you're trying to accomplish. And a number of people basically said they would like you to distinguish from child protective services. So obviously, they don't have to be scared as you're trying to explain what's going on. And then basically to just time when you do this, right? Like when these caregivers come in with their kids for an emergency, maybe wait till the emergency is done and they feel safe and they're ready to go home. And at that point, it seems like a better time to kind of approach them to talk about additional resources and needs. Overall, I think it's a really interesting study. Obviously it's limited since it's a single ED, and so its external validity is maybe not completely valid and generalizable. But it's interesting to see that depending on how you approach a family depends on how readily they are to accept resources.
Yeah, I think the key is that this is one center. It's Children's Hospital of Philadelphia. It's a highly specialized tertiary center in downtown Philadelphia, and it's going to have a very unique patient population. But it's also got a very unique setup with expertise and a social mission and all these things surrounding it. This is a demonstration in I wouldn't say the idealized setting, but it's certainly the idealized sort of like resources for delivery, in a sense, and how well they could take this toolkit and implement it at a different center is probably the biggest question for me.
Yeah, exactly.
Great. We'll move on to the next one. Still sort of in the same theme, but this one's called Patterns of Intramuscular Chemical Sedation Use for Patients Receiving a Mental Health Consultation While in the Emergency Department. The lead author here is Susan C. Lippert, and the institution is the Kaiser Permanente Oakland Medical Center. And keeping on with that social determinants of health sort of theme, it's another look at the disparity in treatments for patients in the emergency department, this time using the Kaiser Northern California data set. These authors are just looking in the mirror regarding their treatment of patients for whom a mental health consultation is requested in the emergency department, and then looking at what percentage required pharmacological treatment with intramuscular antipsychotics or benzodiazepines, and whether certain patient groups were overrepresented. And so 11.7% of the 94,000 ED visits examined included intramuscular treatment, and the characteristics of those who required treatment versus those who did not were markedly different. Those who required treatment displayed obvious differences in diagnoses, particularly psychoses and drug use disorders. And then Black ethnicity, high deprivation index quintiles in law enforcement custody. Those requiring physical restraint and those with a legal hold were also more likely to receive pharmacologic treatment. Unfortunately, there's not a lot here that isn't simply descriptive, and there's not enough here to indicate that treatment decisions were driven by any sort of bias. A different approach, such as a sort of propensity-based analysis, might give clues to that, but these patients are almost certainly wrapped in all kinds of noisy and confounding data or data missingness. And lastly, the only other thing to mention, and this shows my increasing distance from the United States, when I left, it was very much frowned upon to describe any sort of pharmacologic treatment of mental health patients in terms of restraint connotations, such as chemical sedation. And these authors use that terminology freely. And the gist of this article is somewhat along the lines that intramuscular medication is necessary due to patients lacking capacity to refuse treatment or requiring involuntary treatment. Chemical sedation, the generally accepted descriptor these days again?
I'm not sure. I mean, we use it colloquially quite often, but what you're generally trying to achieve here is some degree of safety with these patients, right? And so, which will usually come with some degree of sedation.
Because I was not at Kaiser all that long ago. We used to frame this sort of involuntary treatment as more of a medical stabilization of their agitation, which would have had some sort of underlying either psychological or substance abuse etiology. We didn't necessarily call it chemical sedation, and definitely stayed very far away from any constraint, any sort of connotations of restraint.
Sure, but a lot of that is just how you frame things, right? In the end, here you're giving them a medication to calm them down and protect yourself and them until you can do a further medical workup, or until whatever is leading to their agitation passes, and usually requires some amount of sedation, right? Most of these people go to sleep after you give them the medication.
Yeah, but back to the gist of the article, I don't have anything to say other than this is descriptive, and there's probably a lot more work to be done to figure out exactly if there's biases underlying these sorts of the subgroups that are receiving extra treatment, or whether this is actually just a reflection of appropriate medical practice.
Yeah. I mean, to me, it seemed like a very unsurprising group of patients that were receiving this chemical restraint or chemical sedation, right? Like, these are the groups that often need it. I think you would have to look deeper in more subsets to see if there's bias here.
It'd be very interesting to interview some of the people, if they ever did a qualitative study of the people who actually received chemical sedation and looked at the patient and their family members' perspectives on sort of the treatment they received in the emergency department, specifically for those kinds of patients, and perhaps compared it to other patients who are similarly matched. But that's another set of research that maybe these people will do someday.
Yeah, I imagine those results would we wouldn't like it as much as we. It would be somewhat dark.
Lots of interesting ethical questions for an IRB to answer around that too.
Yeah, indeed. All right. Our next paper is the National Pediatric Prehospital Readiness Project, the first comprehensive assessment of U.S. EMS agencies. And the lead author is Catherine Adelguy. So, I mean, I think we all probably have like a top 5 of most feared presentations. And I imagine many of us, especially those that don't work in specified pediatric hospitals, a lot of our top 5 is sick kids. And we've done a lot of work on pediatric readiness of emergency departments, which has shown that a lot of our emergency departments is not as ready as we'd like them to be if a sick kid would show up. And so what these authors basically wanted to do was take that kind of same survey and apply it to the pre-hospital environment. And so they did a cross-sectional survey that was collected from January to July of 2024. And it was basically open to all agencies who were 911 responding, EMS, fire, and rescue across the United States. The authors created basically a huge survey questionnaire organized across 8 domains to assess readiness as they deemed appropriate readiness for pediatric care. And a lot of this has face validity: educational and competencies, equipment and supplies, patient medication and safety, patient family-centered care, policies, procedures, etc. And they essentially sent it out to all these providers, and they got a certain amount of back, and then they just basically looked at how ready were each of these sites by as defined by this survey. Over 15,000 agencies were invited to participate. A little under 50%, 46%, responded. Most completed a median of 159 questions out of a 200-question survey. And basically what they found was 72% of these groups were ALS certified, 57.6 were fire-based, 62 municipal county funded. So kind of a vast swath of difference, but a lot of this seems to be the larger groups that had government funding and had ALS certification. Overall, the median pre-hospital readiness score was 65.5%. I'm not sure exactly what that means, but that seems to be your median score. The domains that scored the highest were equipment and supplies, policies and procedures, and patient medication and safety. And the lowest scores were interactions with systems of care, patient and family-centered care, and quality improvement. About 38% of the agencies had a pediatric emergency care coordinator, and about 50% did pediatric equipment and skill checks at least twice a year. Not surprisingly, the presence of an actual specific pediatric emergency care coordinator was associated with a higher odds of having better scores across all 8 domains. So, I mean, overall, I think it's a pretty complex paper. again, I think there's some face validity to their readiness scores. Like the exact numbers and what they actually mean are a little hard to know, but it's really not hard to imagine that centers that had pediatric coordinators, centers that saw more children or had a higher volume of pediatric patients would have higher readiness scores than some ones that didn't.
I mean, this data looks a lot like the pediatric emergency department readiness, sort of survey. There's lots of variability. It all came down to having basically a pediatric readiness champion of some kind. Most people had the equipment. It's a very similar slice into a similar slice of data to some extent. And I'm not surprised there's that much heterogeneity across the emergency medical services. And it's a nice starting point to begin discussions on how to improve the uniformity of readiness and bring the level up for all services.
Yeah, I mean, it's been a little while since we did those studies, but in my memory of them, the EMS groups seem to do better. A lot of the problems with the ED readiness was like they didn't have BVMs for kids, they didn't have laryngoscopes for kids, right? They didn't have the basic equipment you need to take care of a kid. And at least here, it seems like they have that part down reasonably well.
Well, it's also a little simpler for a pre-hospital setting they're not expected to have all the advanced life support equipment that an emergency department has. So if you're talking about having all the different blades and all the different supraglottic airways and all the different bag valve masks and all the different training things and everything else that goes into having resuscitation for a child versus we need to transport this patient as rapidly and as safely as possible, it's probably I suspect it's a much lower bar to hit.
Yeah, I would argue they have a lot less space too, though. Right?
The training behind these people is much lower overall, and then obviously the equipment and space you have to operate is much lower, and the time frame in which you're expected to operate and scope is also much smaller. So, in theory, you ought to be able to have the equipment.
Yeah, indeed.
All right, we're staying with children. We'll go with this next article is called Dexamethasone Treatment Regimen and Clinical Outcomes in Children with Asthma Exacerbations. Our lead author here is Shivam Dave, and they are at the University of California, San Francisco. It is fairly well established that dexamethasone is similarly effective as oral prednisolone in pediatric asthma. As with the limitations of most studies, however, there remains the possibility of small but real differences in treatment, particularly in, say, subgroups with greater severity of illness, concomitant viral syndromes, or other features. But considering we don't have much to hang our hats on, we ought to just be able to use dexamethasone comfortably and interchangeably, and further, dexamethasone with just a single dose rather than more, like 2. This study tries to look at that 1 dose versus 2 question, using observational data from 2 pediatric emergency departments, with the primary outcome of emergency department revisits as their measure for comparative efficacy. They had about 2,000 patients in their retrospective cohort, and, interestingly, about 60% of them were the 2-dose patients. Generally speaking, the 2-dose group was a little bit sicker than the 1-dose group, with higher rates of bronchodilator and magnesium administration. Then, the 1-dose group also manifested a higher rate of public insurance at 72% versus 63%, which also ought to give you a picture of the demographics at work overall. There's also an interesting physician-level heat map of 1 dose of dexamethasone versus 2-dose frequency, with most clinicians at Site 1 universally prescribing 2 doses, where Site 2 had a wider scope of practice variation. But in the end, it's moot. In their propensity score adjusted analysis, there was no association between 1-dose dexamethasone and 2-dose prescribing and subsequent ED revisits after a presentation for asthma. They only have data for revisits to one of these 2 facilities, but it is probably reasonable, as the authors do, to suggest the missingness is going to be distributed in such a fashion to randomly and wouldn't favor 1-dose cohort over another. Retrospective data, but it's grossly consistent with the small sample we have so far. One note also worth considering, this study and its prior used up to 0.6 milligrams per kilogram of dexamethasone in a single dose, and there's no breakdown of the distribution of doses prescribed. We all know by now that 0.6 milligrams per kilogram is an anachronistic relic of a previous age, but it still persists, and there still remains no data supporting 0.3 versus 0.6 and single dose and double dose and all that complexity as well.
Yeah, I mean, we've known this for a long time, independent of what steroid you're giving. You give a lot of a steroid, you give a little of a steroid, it all seems to lead to the same thing, right? Just don't give no steroid. There is some data, not with dexamethasone, mostly with prednisone, but if you give 2 weeks versus 1, there's a slight decrease in the rates of bouncing back. So it's not surprising that in a study like this, with the kind of risk of bias that this has, you're not going to see much difference between the 2.
I don't know what the prevailing practice or cultural pattern is, or whether it's a like just in case the second dose, because there's no downside necessarily or disincentive to give a second dose for most people. I think they tend to believe dexamethasone is fairly benign, and if you've already given one dose, 2 doses of dexamethasone is not a whole lot less benign than the first dose. Not everybody loves steroids, and it doesn't always agree with everybody, but I think there's probably a prevailing notion that more steroids is better.
Yeah, I mean, I think it's just an ease of use with one and done, right? You don't have to give them prescription. You don't have to say, hey, take this second dose 3 days later, or the idea that you just have a little more sustained reach of your steroids when you give them a second dose.
I love giving a single dose.
Yeah, me too. In fact, a lot of times EMS has already given it, so I don't have to give any doses.
And they're ready to go as soon as they arrive.
Yeah, exactly.
Best case scenario.
Yeah, upfront dexamethasone.
Yeah.
All right. Our next article, characterizing emergency department visits to pediatric hospitals after local disaster declarations. And the lead author is Alexandra Baker out of Boston's Children's Hospital. So this is an interesting article, basically looking at ED utilization after a disaster to try to figure out how pediatric emergency departments should prepare and kind of stretch their resources during any disaster. So basically, this was a retrospective study carried out from 2010 to 2023 using the Pediatric Health Information System, looking at 45 emergency departments, and they linked that with FEMA major declarations occurring within 50 miles of these hospitals. And they broke these disasters into 5 different categories: severe storm or flood. This included hurricanes, tropical storm, coastal storms, etc., snow or ice, fire, tornado, and earthquakes. And they essentially looked at weekly ED visit volume after this disaster declaration. And then they went a little farther by basically looking at subcategories of ED visits during that time period to try to figure out if any differences. And so 45 hospitals over this period. And what they found is overall, looking at all disasters as one big group, they saw a dip in ED visits over the first week after the disaster occurred, which then slowly returned to baseline over the next 2 to 4 weeks. When you broke it down by different disasters, it changed a little bit. So severe storms and floods basically stayed essentially flat, was a small decrease from baseline, but essentially flat over this 4-week period. Snow, ice, and storms had a large dip initially, like an 11% decrease in the first week, and then recovered to baseline by week 4. Fires was the one difference out of the group, or the real outlier. This actually showed an increase in ED visits in the first week, and then actually continuing to rise over the first 4 weeks. Tornadoes basically showed a decrease initially, and then it continued to decrease over the 4 weeks. And then earthquakes showed a dip that then returned to baseline by week 4. So then they went a little bit farther and looked at the various diagnoses and broke down what you were seeing in the emergency department over that time period. So severe storms and floods, increase in asthma and seizure diagnosis early on. Snow and ice showed basically a decrease throughout, but mostly a decrease in GI symptoms, trauma, fever, asthma, followed by a rebound over the next few weeks with an increase in trauma and skin conditions and seizures in the 2 to 4 weeks. Fires by far had the largest effect. You saw a huge increase in asthma and respiratory complaints in the first few weeks that actually went up by week 4. And then finally, tornadoes, there was just kind of a broad decline over everything, which was similar with asthma. All in all, I think it's a pretty interesting article. Again, the granularity of this data is a little imperfect, but I think the 2 big take-home points from this is you can't think of every disaster as the same. And if you're trying to build like a readiness system for pediatric hospitals and how to flex your resources during and after disaster, kind of can't be a one-size-fits-all. And you have to look at these different disasters as what they are, different disasters.
Yeah, I mean, it's kind of interesting. I mean, I think it's kind of expected that ED visits go down because it becomes some of the less emergent complaints have more challenging transport to the hospital during the time of a disaster. So you have that initial decrease followed by the various increases, unless, of course, you have something that just pours particulate matter into the air and changes the air quality, and then obviously you have the respiratory illnesses. I mean, we see that all the time, just with not even with a federal disaster declaration. reason. If the weather is really bad outside, people just don't come that day. Their minor ailment can wait until things are better. And that's basically, I think, probably that same sort of thing that's manifesting through this paper. All right, last article for this month is called Physician Perspectives on Diagnostic Uncertainty in Radiographic Imaging Reports for Pulmonary Embolism, a qualitative study. Our lead author here is Lauren Westafer, and she's at the University of Massachusetts Chan Medical School at Bay State. And this is an interesting study and an exploration inside your mind. Your mind, the one listening. And this is about what goes through your head when you get one of those CTPA results that is equivocal for pulmonary embolism or cannot exclude segmental pulmonary embolism, etc., etc. And this is part of a larger study looking at practice patterns surrounding the evaluation for pulmonary embolism, a qualitative element interviewing a mix of primarily emergency physicians and internal medicine physicians regarding their cognitive processes. All in all, they interview 42 physicians regarding their concerns, particularly around whether they perform additional follow-up studies and their decisions around anticoagulation. And overall, the responses can only be described as depressing. And most of the representative quotations surround the idea of basically being carried along with the tide to do things they know are suboptimal care. For example, there's a section devoted to fear of PE, which describes not so much fear of PE, especially considering these are uncertain radiology reports. It's really fear of possible liability or quality assurance nastygram. And then there's a theme, treatment is the path of least resistance, where representative quotes basically say, well, I wish I could sit down and discuss this with the patient, have a shared decision-making conversation. But man, who has time for that? And the documentation I'd have to make in my note to make it bulletproof? Forget it. It's easier just to start anticoagulation and kick the can down the road to someone else. Then they asked if people would repeat the CTPA or do an additional test if they were faced with an uncertain answer. And again, nope, we're not going to repeat the CTPA to try and get a better quality study. Can you imagine the ED length of stay? And at least one helpful answer describes going ahead and doing some completely non-indicated tests to support the decisions around anticoagulation. So overall, it's a super fun read. And in the end, the final gist is that clinicians want more structure and guidance around these edge cases. And I'm thinking this is the theme that's going to bring it to us.
Yeah, I think it's funny because I'm sure the older generations who are using VQ scans are welcome to our world where every scan, right, you had so much
just a probability,
uncertainty, right? And so I think it brings home this idea that we don't often discuss, especially with modern testing, where we treat everything as a yes/no dichotomy, that everything is just changing the certain amount of uncertainty, right? You exist with a certain amount of uncertainty before the test, and you exist with hopefully less uncertainty after the test, but there's nothing that's defining. We're just trying to drop our level of uncertainty to a level that's safe for the patient. And if you think about it like that, then some of these decisions become less difficult.
But I mean, to do that, you'd have to have a pre-test probability and then have a posterior test probability, and you have to incorporate something into that, and and then you have to incorporate the risk of them having a bleed versus the risk of this equivocal PE actually causing it to increase morbidity. I mean, but basically what they're saying is they need a structure around this that gives them better guidance so they can actually, whether it's helping them make those calculations or whether it's some sort of protection against not anticoagulating, which they want to do, or a better way to have this conversation with patients, yada, yada, yada. There's a whole lot of stuff that goes into this, obviously, because this qualitative work goes into the brain of the physicians. And so they've identified the needs of what they need to create. And I'm guessing, like I said, that Lauren Westafer and her team are probably going to be working on this.
Yeah, I mean, I think the other interesting thing is the uncertainty of the read versus the uncertainty of the scan, right? I've noticed more and more of our reads are coming back with a lot of hedging in the report, but the actual scan itself is really, the quality is the same as it was before. And so you wonder if you're just changing your wording slightly, and maybe that's based on the radiologist practice and how they feel about their risk assessment versus our risk assessment and how that changes our actions.
Cannot exclude. Blah, blah. Incompletely opacified, pulmonary tree, et cetera, et cetera. Well, the best way to get to reduce the amount of problems you have with CTPA reads is just to not order CTPAs to start with. And the best way to do that is not to order D-dimers to start with.
The hardest question
that's a luxury I have over here on this other island.
Yeah. I mean, I often tell my residents the hardest decision is who to put on the pathway. After that, it's pretty straightforward and easy. But you put too many people on the pathway, you're going to get a bunch of stuff at the end you don't know what to do with.
I tell my trainees the road to hell is paved with D-dimers.
Like you get an uncertain CTP. Why don't you just order a D-dimer? That'll fix it.
All right.
Yeah, I think that wraps us up for another month. As always, with any questions, comments, or concerns, we can be reached at annalsaudio@acep.org. Otherwise, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.